Hi everyone, my name is Martijn and welcome to the second episode of our Let's Talk Oral Health webinar series. We've got an exciting program for today, so let's jump straight into it. While I'm introducing the speakers of today, just let us know where you're from and more importantly, what your professional challenges are in orthodontics. And also, don't forget to like this video on YouTube when you're there. If you're watching on Eventbrite, so the registration page, a small tip, click on the Go to YouTube button, which is in the left bottom corner of your video screen. This will take you to YouTube, and this will allow you to ask us questions and interact with the speakers and with other people in the audience. So today we're talking about home-based oral care from the perspective of orthodontics, and we have two amazing speakers who are really eager to get started. So the first speaker of today is Miss Alina Fintineanu from Toronto, Canada. Hello, Alina.
Hello, good morning. Well, good morning to you. Good afternoon to you.
So Alina is a dental hygienist with more than 11 years of experience in dentistry and in orthodontics. She is the founder and CEO of Risorius. It's a company that provides professional writing, consulting, and continuing education in the orthodontic field. Again, welcome, Alina. How are you doing?
Thank you so much. I'm great. Honestly, any chance that I get to talk orthodontics is basically the best day ever. So I'm going to try to simmer down my excitement, but I'm absolutely excited and thrilled to be here. So I can't wait to talk all things ortho.
That sounds really, really promising. Let's continue then with the second speaker of today, Professor Maria Cadenas from Leuven, Belgium. Hello,
Hi,
Maria.
everyone.
Hello. Maria is an assistant professor of the Department of Oral Health Sciences, Orthodontics of the KU Leuven University in Belgium. She's the Erasmus coordinator within the School of Dentistry over there, and she is currently in charge of the research output for the section of orthodontics. Hello, Maria. How are you doing?
Hi, I'm fine. Also very excited to talk in this live webinar. It's the first time I do something with so many attendees and subscriptions online, and I'm especially excited to do it alongside Alina. I think we match really well.
Exciting! I'm really looking forward, and I can already feel you are as well. So that's really promising. Again, thanks both for joining the conversation today. I'm really looking forward. And as you said yourself, and I also noticed this during our preparation calls, I was really impressed by the passion that you both showed for orthodontics. As you said it yourself a few times, you could talk on for hours and hours about orthodontics. And I know we don't have this time today, unfortunately, but maybe you could explain us and the audience why is orthodontics such a beautiful discipline for you?
Well, maybe I can go first, Maria, if you don't mind. So for me, orthodontics was not something that came naturally to me. I wasn't 4 years old and dreaming about being a dentist or anything like that, but I had really, really bad teeth. And I'm originally from Romania. And what everybody knows about Romania is that it's the hometown of Dracula. Now, unfortunately, my canines were pointing in all sorts of directions. So I had vampire fang-looking teeth all over. And I got braces when I was about 16 and a half. And at that time, as well as most of my patients, it was the worst thing that ever happened to me. And I didn't want to smile or anything like that. And as soon as I saw my teeth straightening, which actually started happening very, very quickly, the amount of confidence that I got and self-esteem growth and just the change that it made and the way that I perceived myself was so truly life-changing for me. Because before, when I smiled, I would always cover my mouth. I was always embarrassed to smile. So orthodontics truly and literally has been life-changing for me. And now it is an absolute pleasure dealing with my own patients, seeing their before and afters. My favorite day is taking their braces off and seeing that beautiful smile. And now we're getting a lot more adult patients, which is really great, which is also why we're talking about clear aligners, because a lot of adults are doing clear aligner treatment. And just to see their own confidence and to know exactly how they feel before braces and then after braces and how beautiful their smiles look, it just makes every single day the best day at work and makes it also worthwhile.
Nice background story. I like your personal touch you have there. Yeah, exactly. You're growing. And how about you, Maria? What's your...
I think for me, orthodontics is just, it has a unique mix of factors. You have the patient factor, of course. We have also mostly, as Alina said, children and adolescents, and they are really changing at that age. They start with you when they are very young, and then you see them evolving and really blossoming. And you can really see how the changing of their teeth goes together with the change of their personalities, and how it really gives them confidence and stuff like that. But also then particularly for me, because I'm involved in teaching, I love also bringing a dentist towards being an orthodontist. I see that they are really getting more and more confidence. They are more and more able to do things. Then it's also a very change in discipline towards research and teaching. It continuously evolves, very linked to 3D tools and changing very rapidly. And I think it's really nice to be involved in this change.
Cool. It sounds like we've got a lot to talk about, and maybe it's now the time to get on with the topic of today. And I wanted to start with the most obvious question when talking about home-based oral care as it relates to orthodontics: how to clean and care for your orthodontic appliances, or even better, how to make sure that your patients clean and take care of their orthodontic appliances. Let's start with you, Alina, because you wanted to talk a bit about a hot topic in orthodontics today, as you already mentioned, the aligners. Maybe you want to start with explaining us why it is so important to take care of them so well.
Yeah, I'm more than happy to. So I feel like aligners are very often kind of forgotten when it comes to taking care of your teeth during orthodontic treatment. And nowadays we have so many more patients that are seeking orthodontic treatment. As I touched upon it, a lot more adult patients. And when you have, I have a bunch of props, I'm going to use them. When you have a mouthful of braces, you obviously have, it's very clear to us that you have the brackets, you have the wires, you have ligature ties, power chains, what have you. So it's common knowledge that one of the great assets of doing orthodontic treatment with clear aligners is the ease with which you can keep your teeth clean, with which your patients can keep your teeth clean, because you don't have all these things to clean around. I have a lovely little tray here. So mostly what you have is just at the most attachments, perhaps a handful of buttons, and that's more or less it. You can pop your trays out, brush and floss and whatever you'd like to do, pop them back in, and you're good to go. Nothing else to really clean around. Now, the problem is that your patients are actually at a slightly increased risk of developing caries while they're undergoing clear aligner treatment. And this does sound like a bit of a surprise when you ever mention that to them, because they're like, oh, but I thought that the whole benefit of this was that, keeping my teeth clean is going to be great. I'm not going to get any cavities or anything like that. But the reality of wearing clear aligners is that even if you just look at the aligner, you see how much of the tooth is covered, particularly all those occlusal surfaces are covered. If I turn it sideways, you see the interproximals for the most part are also covered. So the best teaching moment, in my opinion, is when you have your patient coming into you. So I'm speaking to you as if, you're a hygienist. I'm sure we have a lot more than hygienists and whatnot in listening in today. But if you have your patient that's undergoing clear aligner treatment and they come into you and they pop their aligners out and you look inside their mouth, and lo and behold, their entire lunch is in there. And I mean, we've all seen that, and it's the best, especially when they've had a really good sandwich with lots of onions. Like, why do you do this to us? But they open their mouths and there's all this food debris in there. And of course, inevitably, they'll say, oh, I just came from work and I ate lunch. I didn't have time to brush, or I just came from school, because you have a lot of teen cases that are undergoing clear aligner treatment. And that's a great teachable moment at that point, because the thing that's missing when your aligners are on your teeth is the action of saliva. So saliva is something that we all know buffers the acid inside your mouth. It has the cleaning properties as well as the tongue, and your teeth are covered by it. So let's say your patient at noon is going to have their lunch. They don't have time, or they don't make time to brush their teeth, and then they just pop their aligners right on top. So all of that plaque and bacteria and food debris stuck all over their teeth is basically just going to ferment, because you just pop this on top of your teeth. Your saliva has very little chance of really getting into there, not as much as it would if your teeth were not covered by something of plastic. So that action is no longer happening. Your tongue is really not cleaning around there very well. So everything is just, I really like this word because it sounds very scary, but it's all incubating onto your teeth, which kind of sounds like gross, but it's so true. So it's very, very important to really reinforce to your patients that they have to brush after every single meal. They have to take their aligners out, make sure they brush them really well. And this is actually where maybe we can go over how to properly clean the aligners. So the average person will take their aligners out and will brush their teeth, and then they'll do like a really, really quick little scrub. And if you see how far down my bristles are going, they're like halfway into the tray at best. So one of the very common places that people tend to miss when they're cleaning their aligners is all of the little incisal edges and all the cusp tips. And those can be very prone to decalcification, hypocalcification, which is something we'll touch upon later. So it's very important that they really get in there and make sure they're brushing all the way into the cusp tips, including the incisal surfaces. I find that the bottom teeth are even more prone to that because the teeth are so skinny and so close together that you really want to get those bristles inside to make sure you're removing all of that plaque and debris so that you do not create any fermentable carbohydrates that are just going to sit there on your teeth and just start demineralize your enamel. So very, very important to do that. What we typically do for our patients, and Maria, maybe you can tell me what you give your patients, but we like to give them a little pouch or, you know, a little Ziploc bag where they have a toothbrush. Well, they have a case, because my favorite thing to say to patients is on your face or in your case, because otherwise the aligners end up in the garbage. So always make sure that you have everything given to the patient so that all they need to do is just brush your teeth, use a water flosser, whatever you need to do, just make sure your teeth are clean and beautiful.
Often when they come back and they tell you, I didn't have time to brush, I'm just coming from work, I always ask them, did you check Instagram today? Because if you did, you won't have the time to brush. But it always helps, I think, if you have this little kit with you that you can bring with you everywhere, then it's much easier to be able to brush. And sometimes some people get surprised that they have to brush their aligners. And they say, but I change them so often, I get a new pair of aligners, and then why do I have to wash them? And I always tell them, it would be the same as if you had a shower but you didn't wash your clothes. You change them often, but if they're not clean, then you're going to have a problem. So I think it's interesting to say these little things to patients, like you said, in the case or in your face, because these things stick to you, and then these are the things that you will remember then later on.
They definitely do. And honestly, I'm not against a little bit of guilt tripping the patient, especially with the Instagram.
Very healthy.
I'm sure they've probably checked their Instagram. So you're totally right. And I might use that in clinical practice as well. But these funny little tidbits will stay with them. And honestly, whatever it takes to make sure their teeth are being kept clean, very important.
Definitely.
The other thing that I find my patients tend to do a lot is they ask me if they can soak their aligners. And especially when you're initially starting treatment or they're undergoing clear aligner treatment, oftentimes I find that information goes in one ear and out the other. So I like to do a little pop quiz with them after I give them all the instructions. For instance, I would ask, how often will you soak your aligners into hot water? That's a trick question because the answer is never. You should never soak your aligners into hot water. But that's one thing that my orthodontist asked me when I got my retainers, and I failed that question miserably because I was just excited to have my braces off. So that's another rule of thumb. You should never soak your aligners into things like bleach or mouthwash. Anything colored can pick up the color of it. And I mean, you're wearing clear aligners for a reason. So if you're soaking them in like Listerine or something that has, a green tinge or red tinge, and then all of a sudden it's picked it up at the start of treatment, some of our patients are wearing their aligners for 2 weeks to begin with. So how thrilled are you going to be when your clear aligners are not so clear because you've soaked them into all sorts of things? So that's just not really necessary. All you really have to do is just make sure you take your toothbrush. Don't even use toothpaste. That's another really big key thing that people like to use. They like to use toothpaste. And Maria, I'm sure you're going to tell me exactly what toothpaste does to the aligners, right? It's abrasive. So most toothpaste are too abrasive to use on aligners. They will cause little micro scratches, and the micro scratches themselves can harbor plaque and bacteria as well, which is not great. So all you need to use is your toothbrush and either water, or ideally my favorite thing to use is dish soap. Do you ever recommend that to your patients to use dish soap on their aligners?
Yes, and they are very surprised. They always say, but why can't I use toothpaste? Because this is not teeth. So they're really not made for these, So, but it is a bit counterintuitive that you would have to use soap, because then you put it in your mouth. But of course, you don't put the soap and then put it in your mouth. You put the soap and then you rinse them correctly and then put them in your mouth. But indeed, the patients are sometimes surprised with this.
That's exactly right. So they always wonder, they're like, wait, what dish soap, like the Dawn or whatever you have in your kitchen? Absolutely. It cleans really, really well. There's also a lot of tablets that are available, retainer cleaning tablets. I'm sure you can get them on Amazon and all sorts of places. Very easy and very inexpensive, especially if your retainers are getting a little bit gunky. So definitely make sure to get those. And if you are prone, or if your patients rather are prone to cavities, let's say they've had them in the past, they get them a lot, you can actually recommend for them to brush at night with a prescription fluoridated toothpaste and not rinse their mouth out. Just spit it out, pop their aligners on top because they need to be wearing them all the time, and go to sleep. And that's going to act during the night as well to increase the the protection against cavities. So I think the fluoridated toothpaste trick is a really great one, and that's one that I only recently started adopting with some of my more high-risk patients. So I think
Indeed, it is a really great tip because actually, if you were to have a treatment trying to prevent these caries, they would give you a tray, like the one of the aligners that aligners are actually having. So I think it's a very good tip to prevent caries. Definitely.
I think so too. It's honestly, why not use the aligners for more than what they're intended for if it's not going to ruin or harm them? So why not? Keep your teeth clean is the short message there.
we actually have a tip from the audience. I can quickly show it. We have Miguel saying, I tell my patients to use the denture brush because it reaches much deeper the liners.
Absolutely. These ones can be so, like, this is a wonderful brush, but a lot of our brushes, especially the ones that I like to use, are so, like, the head is so fat. So it doesn't quite fit into those tips. So denture brushes, that's a great idea. Thank you, Miguel. Wonderful suggestion.
Exactly. So the tip is, the biggest tip is just rinse with water. We even have this nice visual.
Yes, exactly. So if you're stuck, let's say your patients are like, oh my gosh, it was really busy, we had to get back into the meeting. The very least they can do is rinse their mouth and rinse their trays with water. Like that's like the bare minimum. If you can, chew a little sugar-free gum with xylitol, but at the very least you should be doing that. Ideally, clean your teeth really well before popping them back in. Do not ferment bacteria onto your teeth. There is no saliva, higher risk of caries.
Yeah, thanks so much for these wonderful tips and tricks. Now, Maria, I think you have some tips also to share, but this time for the fixed appliances, starting with the braces.
Definitely. So with fixed appliances, the way you brush is a little bit different, but it really depends on the type of fixed appliances that you're wearing. Either they are buccal, so just on the top of your teeth, or they are lingual in the inside of your teeth, or you are wearing any sort of fixed expander or appliance which is attached to your upper jaw, or you're wearing a fixed retainer. So I would like to give some tips to the different types of appliances that people can be using. In general lines, for any type of fixed appliances, I would say that the golden rule is be very thorough. So make sure that there is no food left behind, but be also careful so that you don't detach the appliances that are in the mouth. If you are using fixed appliances and you are also using additional help, for example, intermaxillary elastics or wax, if there are some places that are sharp and you're using wax, make sure to remove them before you start brushing. So it has to be only the appliances in the mouth. When it comes to buccal fixed appliances, so the traditional braces on the buccal part, so in the surface of your teeth, we normally recommend to use the modified Bass technique, which I think Alina will be showing. So that's it. You have to use your toothbrush, whatever is manual or electric, and angulate it 45 degrees towards the gum. So like this, you can make sure that you are brushing over the braces and underneath below the braces and the bands. Make sure you get to the last molars because they also have appliances. And even if your last molar doesn't have appliances, this is an extra reason to brush there really well, because a lot of plaque is going to have the tendency to stick to those teeth. If you don't use the brass technique, maybe it's useful to get one of these brushes that have longer fibers on the external side. So the external fibers are longer, and then in the inside they have a U shape. Yeah. And these ones inside are shorter, and the idea is that they will allow for the places for the braces, and then you will really brush on top of the braces and below. Because if you brush normally, then you would not reach those places, and especially the part that is next to the gum will make the gum swell. So that's very important. Also make sure, remember that you have a wire, so it's important that you brush also underneath the wire. And to do that, you can use a solo brush or you can use an interdental brush. In the upper jaw, you can just use it without angulating it. But if you have an interdental brush and you want to brush in the lower jaw, then you can also angulate it so it gets to the parts that are more difficult to reach. So between braces, like Alina is showing now, and underneath the wire, you should also brush because those areas are very likely not clean only with your brush. But also be careful that you don't remove any of the ligatures and things like that. Some articles actually suggest that using a water irrigator, it's softer than using an interdental brush to clean between the braces, and that it actually leads to less detachment of ligatures, for example. But if you can't use a water irrigator, it's also good to use an interdental brush, being careful. Then if you use lingual fixed appliances, which are actually in the inside of your teeth, these are a little bit different. The principle is the same, it's just the surface where they are attached is different. And there's an article that was published in 2015 in the American Journal that suggests that actually you have less possibilities of developing caries in the lingual side of your teeth. And this is just because of the anatomy that the teeth have, that the plaque is actually less likely to stick to the lingual side, but also to the cleaning effect that the tongue actually has. So the tongue is right there and it cleans the teeth really effectively. So you have less chances to have caries. This doesn't mean that you have less chances of caries when you have lingual appliances. So you still have to clean them exactly as well as you clean the buccal ones. So the idea is that you brush on top of them, and then that you use an interdental brush that you angle to get underneath the wire and in between the teeth. Make sure that you also get to the last molars so that they're also clean as well. Then I would like to go to fixed expanders. This can be, for example, a Hyrax, like we are seeing on the screen right now, or a distractor, or even a Quadelix. They can be all sort of fixed palatal appliances. So you, of course, are expected to brush your teeth in a normal way on the buccal side, occlusal side, and the lingual side, and so on. But then you can use a large conic, if it can be, interproximal brush to brush underneath the expander. So you can. It's important that it is large, that the handle is actually long, so that you can really get to all the nooks and clean everything up. It's quite useful if you angle it, so you can use your fingers to give it like a curved shape, and then you can get really in between the appliance. If you show the pictures again, Martin, then you can see, yes, exactly. So to make sure that there is no food attaching between the palate or the gingiva and your appliance, because these brushes are very soft and they're not going to hurt your gum. Don't be afraid of that. But it will hurt if there is food left behind and the gingiva starts to swell, because then it would really grow on top of the appliance and then it will be very painful to brush. This enlargement of the gum we are going to talk later on, but it's painful, so avoid it, because it normally happens because of retention of plaque.
Actually, Maria, can I interject there for one second? One of the most vivid things that I remember is a patient that had a rapid palatal expander. So it was something that looked something like this. So it was glued onto the first molars on each side. And he had just one spot that was very, very angrily inflamed. It was very red. It was bleeding. He was telling me that it was hurting all the time. And all I had to do was literally just a little bit of exploring around the area, and the popcorn kernel started coming out. And and then we went back to the whole story of what are the things you're not supposed to eat with expanders.
Popcorn is a silent killer. It's something that you should not eat when you have braces or appliances, definitely. So you just have to avoid that the gum ends up swelling. So the idea is that it doesn't swell, then you will not have bleeding or pain or anything like that. And these proxy brushes that I'm talking about, you can find them in nearly any supermarket, and sometimes they even have replaceable heads. So they're quite easy to use. Then lastly, I would like to go to fixed retainers. And these actually come in all sorts of shapes. Like you can see in the pictures, you can have them attached only to your canines. You can have them attached to all the teeth. They can have different shapes and stuff like that. The idea is that it's easier to brush, but whatever type of retainer you are wearing, it's very important that you try to brush really well. You can't floss, of course, but with most of them, but you can use interdental brushes, so do it. Try that there's no food coming in, because of course your gingiva can swell as well, but also there is more tendency for plaque retention with these appliances than if you don't wear them. So it's important also to go at least once a year to professional cleaning, so that the dentist or the dental hygienist can see that everything is okay, that there is no caries, that there is no problems with the gingiva as well. But also it's important to check regularly whether these appliances are detached in one of the teeth or in several teeth. Because if you do detach, they can provoke undesired movement of the teeth, so relapse, but they can also create activity in the wire. So if they are detached and the wire twists, then this can create a movement of the teeth that we don't want, and the root can even be pushed in a bad direction. So it's important, if you see that they are detached, that you immediately come back to your orthodontist.
Maria, can I one more
sorry.
thing, if you don't mind, on that topic?
Yeah.
So when it comes to the lingual wires, if I'm sure for all of the hygienists that are in here, I'm sorry. I know you really, really hate cleaning them. They really are a pain, honestly. But there's one other thing that I was just thinking of, because I have seen it myself before I used to work in orthodontic practice, is if you find that the patient is telling you that they can't clean between the teeth and they can't get in there, especially for the bottom ones where there shouldn't be any sort of interference with the bite. So there's no reason why it should go very, very gingival or anything like that. You might want to take your Explorer and just walk it around the margins and make sure there's no excess primer or excess bonding material, because sometimes it does happen. Isolation in this area is very, very difficult.
Yeah.
I place these myself, and I'm sure Maria does as well. And it can get very tricky keeping the tongue out of the way when you have a squirmy patient that's really excited that they got their braces off. They want to get the heck out of there. So sometimes it does happen that a little bit of primer flows in there, or something that blocks the interdental spaces. So while you're cleaning, of course, you're going to be removing all the tartar, but if you can also check to see if there's anything that's actually preventing the patient from flossing the area. We never were upset of anybody sending a patient back to just have a spot cleared out or anything like that we might have missed. It's great to bring it to our attention. And just like Maria said, you're in the perfect position to check whether those pads are loose, because the patients often will not know. And then the most annoying part, I think, for hygienists is when the patient didn't realize it's loose, and then they're like, oh, the hygienist broke it at the cleaning.
Yeah.
For all the hygienists listening to this, I'm sure you're like, oh my God, it's happened for sure.
Definitely. And some of the things that can happen as well, I think, is a very important thing when you are placing one of these retainers, not to be too generous with composite. So please just don't put there 1 kilo composites. It's not necessary. Just a very small spot to make sure that it's attached, but that the tissues are clear and people can brush, because otherwise this plaque is going to go underneath of this composite. It's going to look, it's going to have another color. It's going to look bad, and the patient is going to think it's caries and things like that. So it's important to place them really discreetly. But then a second thing is, and I think it's interesting also for oral hygienists, that if you have a patient where you have this attachment of these fixed retainers again and again and again, and you don't know what's going on, you started to think, is it me that I'm placing this wire badly? Ask for oral habits. Ask if you have a nail biter in your chair. Ask if this patient, or check if this patient has tongue interposition, for example, because these oral habits can actually lead to detachment of the fixed retainers, but also to activity of the retainers. So whenever I see a patient that has the lateral incisor and the canine completely in inversion with a wire, I ask them, do you bite your teeth on the right side? Because then I know that it's a nail biter that I have in front of me. So those things they really have to have under control, because otherwise you have problems.
And that wire really can become very, very active. I've seen it a couple times as well, where they'll bite something, especially right dead in the center. They'll bite like a nut or something like that, particularly when they have the wires that are only glued to the canines, which unfortunately we don't do anymore. They were a lot easier to clean. And the wire just distorts downward completely, and then everything just starts shifting, which is...
Yeah, you can have periodontal damage and all the other things. So that's not nice.
Absolutely.
If I may, I assume that these tips are suitable for the sort of the general patient in general practice, the sort of undergo orthodontic treatment. What about patients with special needs, especially you, Maria? You work in university clinic. You probably only see complex cases, and you see a lot of patients with special needs. How do you deal with those patients and those needs?
Well, it depends on which are the needs, because under the label of special needs, you can have a big spectrum of people. You can have people that are physically incapable to brush, but you can have people that are just not being able to do absolutely anything, or understanding that they are actually being brushed. So it's important that you determine which are actually the needs of the patient, but also it's important that you know which is the support that this patient is having from the environment. Does this patient have very committed parents, or does it have a caretaker that is completely overwhelmed with work? So it's important also because they need to understand also how important brushing is. If they don't understand it, then probably the patients will not brush correctly either. I am a big fan of letting the patient do whatever the patient can do, because otherwise you are ignoring this person and only directing your information towards the caregiver. So I think it's important to see what does this patient what can this patient do? What is the patient doing now? And then be really hands-on when it comes to your demonstrations. So ask them first, how do you do it? How do you brush? Show me what you do on themselves, but maybe also on a model. And then explain to them, this is what you're doing right. This is what you could do better. And also explain very basically to the caregivers what should be happening. And if the patient can brush, then let them brush. And then ask the parents or the caretaker to check again that this is actually being done correctly. There's no shame in someone checking how you are brushing. It's all for the greater good. So it's important that they check. Also, we should adapt also our language and our way of explaining to the possibilities of the patient. Especially, for example, if the patient has a hearing impairment, then we have to speak a little bit slower so that they can read our lips and things like that. And it's important, in my opinion, but maybe you can tell me something about this, Alina, that there is a good connection between the patient and you. Because if they like you, they are more prone to try to do what you're explaining. I don't know if you have any comments on this.
That's, you know what, I couldn't agree more, because patients like that can be very particular about who they see. So establishing that relationship is very important. Whereas in general practice, you might see that patient over and over for years and slowly build up the trust and everything like that. But in our practices, whenever we would have patients that were perhaps on the autism spectrum, they would prefer and feel more comfortable seeing the same person. So in our cases, we would write a name with a star of who they're used to seeing and who they trust and who they feel comfortable with, because you definitely don't want to be springing changes onto them, especially when you're trying to introduce new skills or new home care practices. So trying to stick with the same practitioner if possible, I found that very, very important.
Yeah, and it's also the only way of assessing if they're actually improving, because then you have the reference from the last time. And I think it's important to motivate them every time that they come back. They're normally very proud. Nice to encourage them. Also, it's important for them to know that there are different brushes with special grips. So you don't only need to think that there is one type of brush. There are brushes with other types of handles that may be easier for some people. So it's worth it to check on the internet the options that there are. It's important to tell the people in their environment as well that you don't have to just settle with the normal general options that there are for general public.
We had a webinar on caregivers last year, and we had a few tips like this. You can, if you cannot find, for example, a toothbrush with such a grip, you can simply put tape around it so that it makes it, more grippy. And you mentioned the hands-on instructions, and you mentioned autism also, Alina. I remember from last year, it was said that you could also sit behind the patient so that it's not too confronting, because when you're sitting in front of a patient, then, you're the guy sitting in front. If you sit behind, put the brush in the hand of the patient and put your own hand over it and then brush, it also gives sort of a feeling of autonomy to this patient. So yeah, maybe that's also, I don't know if you agree, but maybe that could also be a way to sort of introduce the correct brushing method.
I definitely think so. And it's also, I always found it very important, and not only with patients that were special needs, but with really all younger patients, to get on their level, where if I was giving them any sort of instruction, I would not be hovering over them or standing over them where they feel like they're being talked down to. Instead, I would keep sitting in my chair and roll to either face them or behind them, whatever I felt was a little bit more appropriate. And when you're just a little bit more eye-to-eye contact, they just feel a lot more heard and a lot more listened to. And I mean, ultimately, all kids want us to be taken seriously and to be listened to. And if you can do that and create that kind of connection with them, they're sometimes more likely to listen to you than they are to their parents and whatnot, because you're there in like a professional setting versus their parents that probably tell them this day in and day out. So I think getting that connection and having that rapport is very important.
Yep. Now, I see we are already 30 minutes in. Time to move on to the next topic. But before we go, I just had a look at the questions in the chat box, and there's actually a quite interesting question that we haven't mentioned from Andres. Andres asks, what would be the best toothbrush for aligners, with hard or with soft bristles? Do you have any tips?
I'm always wondering why they keep selling hard bristle toothbrushes, because they're so bad for your teeth, but somebody must be buying them. So I would say don't complicate yourself. If you have a patient that has aligners, it's much easier to have them just use a toothbrush that they're already using in their mouth. Brush your teeth, rinse it off really well, and use the same one into the aligners. Or the denture brush, I think, is fantastic. But I don't know that you necessarily need to worry about the bristles. It's more the mechanical removal of plaque and more the different shape of bristles if you feel like they're not quite getting all the way into the cusp tips themselves.
How about this? Another question before we jump on to the next topic. It's from Francine. Francine asks, would you dipping the aligner in fluoride rinse before wearing it would be recommended? Is that a tip you can give to
Honestly, I
clinicians?
don't think I can really see an issue with it as long as you're not using, again, any kind of fluoride rinse or any sort of mouth rinse that's going to be very pigmented. So you definitely don't want to dip it in anything like that. Make sure always it's lukewarm or cold. I don't know how much uptake you really would get from the fluoride itself. So I think it's probably a little bit more effective to just brush with the really fluoridated toothpaste, spit, and then pop the aligners on top. I feel like that's going to provide maybe more of the fluoride.
Yeah, I think the problem with the uptake it's definitely an issue. I think that's the reason why fluoride treatments are normally recommended to use at night when you are not having a lot of movements of your lips, of your tongue, and things like that, and then the product is more likely to stay in place. Now during the day, I don't know exactly how much intake the tooth will actually do of the fluoride, but indeed, yeah, I don't see any direct contraindications to that.
Okay.
Sure. Cool. Yeah, thanks so much, both of you. There's so many tips and tricks for everybody who's watching and wants to look it back or go through them slowly again. Please know that this recording will be stored in our YouTube channels. You can always watch it back for free until eternity. So yeah, be comforted with that thought. Now, I assume that one of the reasons why you want your patients to take care of their appliances at home very well is because you want to prevent one of the biggest nightmares, probably would say, in orthodontics. It's the white spot lesions, very nicely depicted here. Maria, as an orthodontist, could you maybe shed your light on the basics of this important issue? What are the definitions, signs and symptoms, the causes, etc.?
Pleasure, because I would love to live in a place, in a world where these lesions were not existing, because they are really a nightmare for patients and for the professionals as well. So the basics behind these lesions are that when you don't brush correctly, then you will have accumulation of plaque. So this is just food that gets between your teeth, on top of your teeth. And if you don't remove these accumulations of plaque, then they will get colonized by bacteria. And these bacteria are going to start creating acids. And these acids are, of course, not good for your enamel of your teeth, so they will start demineralizing them. So then we see these lesions that are a bit chalk-like. They look like chalk, the surface. They're whiter than the teeth, and that's why they're called white spot lesions. The ideal situation is that you never get to have a white spot lesion. So the ideal situation is to prevent them. Because after they are there, after their onset, they are very difficult to solve. And then Martijn is showing now a reference of some articles that show some strategies to remineralize these lesions, but the literature is actually not clear, however, on how efficient these methods are. You can see some clinical improvements, and Alina is going to talk about it later on, but we can't really say that these methods are really remineralizing the surface of the teeth. What you see now on the screen is a reference of a systematic review that was published really recently that is studying including all the studies that have been done until now on remineralizing agents, so all the products that exist and how efficient they actually are. And this evidence is very contradictory. In some cases it works, in some cases it doesn't. So there is not really a clear answer to whether they work or not. So still the message is try never to get a white spot lesion. So work on prevention. If you want to dig further on the options that there are, then you can read this article because I strongly recommend it. Then I don't know what you think about this, Alina, but in my opinion, some patients are more prone to this kind of lesions than others. I suppose it's because of the anatomy and histology of the teeth. Genetically speaking, they may be more prone to it, the saliva and things like that. Brushing is very important, so your brushing habits are very important, but also food and drinks. So carbonated drinks are not helping whatsoever. Intake of sugary foods are not helping, and not brushing is also not helping. So I think, or at least what I do, if I see a patient already has some white spot lesions before starting orthodontic treatment, then for me is a no-go to start. They really have to have their hygiene, oral hygiene controlled before I start, because otherwise, if you start, the situation is only going to get worse and worse. And when removing braces on a tooth that already has white spot lesions, you have big chances of removing a lot of enamel and breaking the surface when you are removing the braces. So it's important to be careful as a practitioner when you are removing the braces, because otherwise the surface can be cavitated further. Just a situation that you don't want to leave, because it's not nice at all.
That's honestly so true. And I remember having to see that enamel and basically the way that it was kind of crumbling underneath my scalers and whatnot. And you felt so bad, and you can't use the Cavitron on it, and you can't really hand scale it because it's just, you're really gouging out the enamel, which is just terrible. So I think you touched up on so many important points there, Maria. I think white spot lesions and decalcification are like the worst case scenario really for braces. And there's a really shocking statistic that says around 5 to 95% of patients undergoing braces will have some sort of white spot lesion, which is really, really scary. Now, if I can offer you a couple more fun facts about it, white spot lesions can develop as quickly as 4 weeks. That's it. That's all it can take, which is really, really scary because it's really fast. And there was a graph actually online where it showed that the incidence of white spot lesions was rapidly increased in the first 6 months of treatment. So what's really important is the first 6 months to really being on top of the patients, making sure they're brushing, making sure they're making those good habits, because that's those 4 weeks. And then the first 6 months are when the highest increase of these lesions happen, with a gradual increase afterwards, but at the start is really when it's the most crucial part of it. Decalcification, I mean, if we really look at the etymology of the word, it's made of D and calcium, so it's a loss of calcium in the enamel. So this really is the first and incipient stage of caries, which is not great. So I mean, we're going to go back to that fear mongering. If you must, like, tell them that this is a cavity starting to form, which is not good. Your tooth is a lot more susceptible to it, and we need to do something, and we need to arrest it. We need to not let this progress any further, because like Maria said, the literature is very spotty on what can help and what, you know, what patients will respond to it, what patients won't. But there's no way of telling patients that, oh, for sure we can fix this, which absolutely cannot be the case. You know, you can't reverse, especially once your enamel has started gouging out and it's just chipping and flaking away. I mean, a hope and a prayer won't bring that back, unfortunately. So what's really important is, exactly as Maria said, prevention is absolutely key. So the types of brackets that are used, in my personal experience, I found that self-ligating brackets tend to accumulate less plaque around them, because as we all know, if you have a tooth surface that's just a pure enamel, it will be a lot less retentive than anything that's bonded to it, and even so less retentive than any like brackets or anything of the sort. So I found that self-ligating brackets, if you have, let's say, any patients that are considering braces and you think that oral hygiene might be a bit of an issue, of course, that needs to be addressed first. Like Maria said, we definitely do not put braces on to patients who have uncontrolled deposits of plaque and really poor home care. But I find that brackets that have O-ties, so the little colorful elastics, just like you see in here, I find these are a lot more plaque retentive. And then when I remove them, there's a ton of gunk and all over and whatnot. So if there's an option of going between the two, if you want to err on the side of caution, self-ligating brackets are great. The risk you can really reduce by, exactly as Maria said, the mechanical plaque control that you're doing. So make sure that the patients have really, really great oral hygiene. Topical fluoride is always a great thing. Fluoride varnish, whatever you can do to really increase the enamel's resistance to that microbial acid. Also using a fluoride mouth rinse, a fluoride gel. A toothpaste with fluoride is often insufficient, especially when you have patients, just like Maria said, that start off with some semblance of white spot lesions to begin with. So those are the ones you really, really want to be on top of. And you can even try essential mouth rinses like Listerine that really reduce the bactericidal activity, which is really great. In my personal experience, and actually in literature as well, the place where people tend to get the most white spot lesions are the upper laterals on the facial surface. And you can sometimes see it happening. So what I'll like to do to my patients is, once I see it, I'll grab a really nice big handy mirror, place it right in front of their face, and I'll take a scaler and I'll scrub away at the plaque that's around it, and I'll show them that the spots are starting to form, and I'll show them that scary picture that Martin showed for us, and I'll tell them that, you know, your teeth will be beautiful and straight when you take them off, but the enamel could look like that. You could have chalky little squares, and good luck getting rid of those, because they're the starting stages of cavities, which is not great. If we had any patients that had, you know, localized areas that were really, really affected by decalcification, I did find in some cases some improvement with something called MI paste. So that's something that you might want to have in your practice or have handy in case that's something that you can do chairside. But like Maria said, prevention is key. The MI paste, really what it does is it supports the remineralization of the enamel by promoting the uptake of fluoride ions. One key thing to remember there is do not use that on patients who have milk allergies. So just make sure they don't have that. There was a really sad case when somebody used that on a poor little patient that had a milk allergy. So definitely avoid that. But again, avoid if you can. MI paste if you must. Just do everything you can to avoid it, especially in the first 4 weeks and in the first 6 months. And then it's a little bit more smooth sailing from there.
Indeed, you're completely right. I agree with everything you said. It was not a surprise, but the reason why these allergies happen is because these MI pastes is actually containing casein, which is a protein that is contained in the milk, actually. And that's the reason why people that are allergic to milk are also going to be allergic to that. But normally people that are allergic to milk, they say it really fast because you have these proteins of milk everywhere, even in meat and in all these sorts of products. But it is important that you take it in consideration. And also completely agree that self-ligating braces are retaining much less plaque than the others. This is actually also shown in research. So it's completely proven that it's like that. As you can imagine, having an elastic around the braces that is getting swollen with saliva and everything and is containing a lot of bacteria is not helping towards plaque retention. So completely agree with the facts that you mentioned.
Absolutely. And actually, one more fun fact, I guess, of sorts that I never really thought about, but, we like to change our toothbrushes every time we're sick. We say every, 3 to 4 months and whatnot. But with braces, it's much more important to change the toothbrush very, very frequently because of all the wear and tear that's happening because the bristles are rubbing against something metallic, usually.
Yeah.
We have the brackets and the wire, so it's getting worn down a lot more quickly. So just definitely check to make sure that your tools that you have at home are still in good repair and replace them a lot more frequently than you think you need to. Proper cleanings all the time, and that mechanical plaque control needs to really be key. And don't be afraid to scare your patients a little bit because decalcification is such a hard thing to deal with. And I think a little fear mongering can be totally okay if it helps them in the long run. Do what you have to do.
Definitely. And I think, always think about something that one of my professors told me when I was studying, that all the information you give to the patient before you start is information, and everything you say after you remove the braces is excuses. So I think it's very important that you tell the patients the reality we can call it fear mongering, but it's actually, it's the truth. It's actually the bare truth. So it's important for them to understand how important it is and that it's actually health. Because sometimes orthodontic treatment is seen as aesthetic treatment, but it definitely is a health-related treatment. So a lot of things can go terribly wrong. So I completely agree with you.
I think if you look into studies on behavioral change in oral health, one of the factors that has the biggest influence on behavior is making patients aware of the severity of what they're dealing with. So when you're talking about periodontal disease, make them aware that it's actually a serious disease, that can have a negative impact on not only their oral health, but also on their systemic health. So making patients aware of this severity definitely helps in changing their behavior and, making them adopt and making them be more compliant. Maybe one interesting thing you also mentioned, this wearing of the toothbrush, that they become less effective. There's even some evidence that worn toothbrushes are even more abrasive for the gingiva. So when you're talking about scaremongering, could be another argument to convince patients to replace that toothbrush more often, I think. Yeah, really interesting. And maybe now that we are on the topic of gum, of gum health, of the periodontal health, of course, there's another complication that is a danger to your treatment success. And that's the hyperplastic and the hypertrophic gingiva. Our next topic that we want to talk about. What are the causes here, and how do you deal with them during orthodontic treatment? Maria, do you want to have a go?
Yeah, I think it's important to know what is the cause actually of this enlargement, because both terms, so hypertrophic and hyperplastic gingiva, is just a gingiva that is enlarged. So the tissues are just bigger than normal. But both terms are actually different. Histologically, hyperplasia means that we have more cells in the tissue, so the number of cells is increased. And hypertrophy means actually that the size of the cells is bigger, so they have been swollen or they are bigger. And the gingiva can actually enlarge or get inflamed by different reasons, the main of which is, again, plaque accumulation. So if you are not brushing correctly, then the gingiva will be swollen, like we said before. And also this will be the plaque accumulation will be colonized by bacteria. So this is mostly the reason. But there are other conditions that can give this gingivitis. For example, I can think of use of asthma medication. This will give hypertrophy of the gingiva. Hormonal changes. We said before we have a lot of teenagers, so it's important that you know that as well. But also patients that are pregnant, patients that are having hormonal treatments and things like that can also sometimes find this have this problem with the gums. Also breathing through the mouth. So mouth breathers are also having more enlarged gingiva, and it's not only related to the amount of plaque accumulation. So don't be too hard on patients that have other causes for hypertrophy because they can't avoid it sometimes. But also patients that have other dental conditions like amelogenesis imperfecta. So for example, if the enamel is affected by any reason, then the gingiva also tends to be more swollen than normal. So the first thing I would say, tailor-make your advice on how to brush depending on the cause of this hypertrophy. So first asking, is there something else going on? Are you having any medical treatment going on, or is there something happening at this moment? If you see the enlargement of the gingiva is mostly due to the fact that the patient is not brushing, then go full on and tell them to brush. But otherwise, you have to really tailor-make your advice to the situation of the patient.
Mm-hmm.
Maria, I think you were totally right. So you touched upon excellently on the actual etiology of hyperplastic gingiva, and the fact that a lot of us really often forget this, the fact about the hormones. So, we're all very accustomed to having our patients with, pregnancy-induced gingivitis. That's a very commonly known thing that it can happen because of all the surge of hormones. But what we tend to forget, and what I know I've personally forgotten many times before, because, we're sometimes very quick to kind of point the finger as in, you're just not brushing your teeth well enough. But if you have that teenage patient that really doesn't have very much bacteria buildup, that doesn't have all that much plaque, and then you're looking at their mouth and they just have all this swollen gingiva everywhere, what we really should keep in mind is that the patients that very often are undergoing braces are patients that are at the peak of the surge of hormones. They're often teenagers around, 14 to let's say 17 years of age, and these hormones can really wreak a lot of havoc. So if you look intraorally at your patients, exactly like Maria said, you can often tell there are always almost traces of what the root cause of it really is. So first off, let's say we've eliminated amelogenesis imperfecta, we've eliminated the medication. So this is just your typical patient. What I've personally seen in practice is oftentimes the gums at the posterior are totally fine. And then you'll see the gums at the posterior, either at the upper or both at the upper and lower, and they're really, really aggressively swollen. And that's when I start asking myself and the patient questions where if the amount of plaque that's present doesn't really correspond with the amount of swelling I'm seeing, either they did a really good job brushing that day, or maybe there's something else. Maybe they're a mouth breather. Maybe that's something that we need to look into in terms of, maybe it's allergies. They're breathing through their mouth a lot. Is it constant nasal congestion? Do we need to maybe refer them to an ENT? So that localized swelling can really be a point toward something else that might be going on, especially if the amount of plaque does not really correspond with the amount of the inflammation that you're seeing. On the other hand, if you're seeing a patient that's coming in and their gums are grown all over, and if you take one of those interdental brushes and you just brush, honestly, the place that I tend to see it the most is at the posterior teeth, like right on top of the braces here. So all the gums are just completely swollen, and you take your proxy brush and you just do one swoop in there and all the food just comes out. I mean, there's really no further questions, Your Honor, at that point.
Yeah, definitely. You can rest your case at the time. But indeed, what you said is something really important. If you have this hypertrophy of the gingiva on the posterior sides, very likely, 95% of cases, you're going to have a bad pressure. If you do have it on the anterior side, then I would start thinking about a mouth breather or asthma medication. I will always remember this patient of mine, fantastic girl. She really wanted to brush and brushed really well, but she had a very severe case of asthma, and so she had to use inhalers all the time. And she was crying her eyes out when she was coming because she was very embarrassed actually that she had this gingival hypertrophy, because it can get really big. It can look really bad. So for her, it was really a reason to be embarrassed. So it's important for these kind of patients that you don't also go to tell them, it's just that you're not brushing. So it's important to take it into consideration.
So you're totally right. Really need to assess kind of all of the factors in terms of both medication and what we're seeing intraorally before we necessarily point fingers. But again, if you're seeing that plaque, I mean, the proof is in the pudding, as they say. But also, we have had some patients as well that have had super, super swollen gingiva. And the one thing that, we can tell them after treatment is that in a lot of the cases after the braces are gone and it's a lot easier to keep their teeth clean, it's, in some cases it will resolve. You can also recommend saline rinses, which are a really great idea and can help a lot. But in some spots, if the gingiva is really, really overgrown, they might even need like a gingivectomy or gingival contouring if it's really gone above and beyond. And the other thing that you can tell patients is we actually have had some, not very many, thank goodness. I would say maybe 2 in my entire 11 years that we've actually had to remove the braces prematurely because there's just so much overgrowth, and the gum started actually growing over the braces, which is really, really scary to look at. And, you'll say this to your patients of like, if you don't keep your teeth clean, we might have to take these off early. And every single patient is going to be like, yes, because what patient wants to keep their braces on longer? But it's absolutely nothing to celebrate because you realize you're taking your braces off early, not because your treatment is complete, but because your gums are suffering and your periodontal and oral health is suffering so much. And, they're thrilled in the moment thinking that they're getting rid of their braces sooner. But the reality is they're probably going to have to get them back on a second time around to finish the treatment. So why not care for everything once? Get it done properly. The teeth, we all know, move faster when the gingiva is in good condition, when the periodontal health is up to par. So why not take good care of everything so that the braces theoretically should be done once and should be done right. But if you must motivate them, again, do whatever you need to do. I also really like using disclosing solution. That's something that is very commonly forgotten about, especially if you have patients that are insisting like, oh, for sure I brushed today. And then you look at their gums and you're like, yeah, this does not look like what you're telling me. Disclosing solution, especially some particular brands, can tell you how long that bacteria has been on their teeth.
Yeah.
So then how are you going to lie now? So disclosing solution, I think, is really great. Obviously, the go-to brushing and water flossing, interdental brushes are great. I also like to just do the whole mirror in front of their face, show them exactly what's going on, because sometimes they just don't look. They don't look at their teeth and they don't really pay attention to maybe what's happening at the back or the inflammation that's going on. And if you show them what's happening, they might be a little bit more motivated to do something about it when they see the bleeding and everything that's going on. And really just try to focus more on encouragement than warnings. There's a saying that says you can catch more flies with honey than with vinegar. So try to really be encouraging and not too hard on the patients, but also really make sure you're underlining the importance of keeping everything clean, because some things like the decalcification or like the very, very overgrown gingiva are very hard to resolve after or impossible to resolve. The other thing that you can do is, for instance, if your child is undergoing orthodontic treatment and you see that this is an issue, you can even do, honestly, use a little bit of psychology. Let's say you like to use disclosing agent, they're a fan of that. You can set some sort of reward system, for instance, where you agree that you'll do like surprise disclosing solution. And if the brushing is up to par and if the plaque control is up to par, then they get XYZ reward, whatever that may be. There's actually, I know we're slowly running out of time, but there was something that I came across which I thought was really interesting. And it's a psychological effect called the Hawthorne effect. This is something I didn't know about before. And it's basically when patients will behave differently when they feel they're being watched. So what they did is they gave patients a toothpaste. They labeled it something experimental. And they're like, oh, we're doing a clinical trial for this toothpaste. And the patients are like, oh, well, this is very scientific. Like, I'm sure this is going to be great. So they were a lot better on their end with their own home care, thinking that they were being watched, that they were being studied. So that placebo effect or whatever it may be, if it works, it works. So I think whatever effect you can use to keep your patients motivated, if it's psychological, by all means, but as long as they're keeping their teeth clean, keeping their gums healthy, that's the end goal.
I think as a research coordinator, Maria is very much aware of the Hawthorne effect when doing your studies. Research is not what you want, but it's actually very interesting to use it in your advantage as a clinician. Absolutely. As you mentioned, Alina, almost running out of time. We only have 2 minutes left. I think there's some time for some questions from the audience. At least I saw one question that was relevant for the topic that we're just talking about now. And it's a question from Cleo. Cleo's orthodontist said the gingival swelling was because of an allergy to the metal. Is this a possibility?
Maria, I will ask you if you've experienced this in your practice as well, but I did have one patient, and I recall that had really, really bad swelling, and it was mostly on the lips. The lips were very, very irritated, and it was very soon after they got their braces. So we did the saline rinses. And we also checked exactly what was inside, because some of these patients have a nickel allergy. So I would check if they have a nickel allergy, because some of the wires are made of alloy. So you'll have nickel, titanium, and whatnot. So it can be the wires themselves. Whereas I believe the brackets for the most part are made of titanium, but check for metal allergies, because that can definitely be a thing. I believe we ended up switching the patient to clear braces and just trying to make sure we're staying away from those wires, but it did end up resolving. Maria, what experience have you had with that? Have you ever had a patient report anything like that?
Yes, I have to apologize because I've been having problems with my computer, but I hope everything is okay. And then you
Can see and hear you. Yes.
Perfect. Yes, I've had a couple of patients that saw that they had allergies to metal while having the treatment. Normally, patients know it before because, for example, there's a lot of similar metal in jewelry. So they actually already from an earlier age, they know that they have a metal allergy, and they refer it or they say it when you're seeing them for the first time. But if they don't, then sometimes they do develop this allergy, and it normally translates into a gingival swelling. Yes. This is, but then you would see it very early on. So you would see it like immediately after placing the braces.
Yeah, usually when I saw it, it was within the first week. They called us back maybe 5 days after, and they said it was happening. So,
and normally it's to nickel. That's the metal that is that has more allergies that we use in the mouth, because normally stainless steel will not give you any reactions. It's also the same for jewelry, for example. Gold is of course the best metal that you can use that presents less allergies, but it then is of course very, very expensive. So normally we have nickel, titanium. Titanium is very, very biocompatible, so normally it also doesn't give any allergies, but nickel definitely does. So it's important that you know from the beginning. Okay. And then the only thing you can do, sorry, Martin, the only thing you can do is to remove the braces, and maybe you can think about aligners.
Yeah. Thanks so much for answering. I think I'm afraid that that's it for today, unfortunately. I hope all the questions have been answered at least. And before we go, I also wanted to take the time, take a little bit of time to show some take-home messages and go through them for everybody who's watching. Again, this recording will stay online, so you can read them in your own time afterwards. But just to go quickly through them, we listed them together. While wearing clear aligners, teeth have less exposure to the buffering effects of saliva, so it's very important to keep teeth clean after eating because there's an increased risk for caries. Use a modified base technique to brush around brackets and into proximal brushes or a water irrigator to clean between them, around appliances and under lingual wires. For special need patients, provide hands-on demonstration and train the parents, the guardians, or the caregivers to check. White spot lesions are white chalky spots caused by plaque accumulation, fermentable carbohydrates, susceptible tooth surface, and time. White spot lesions can develop as quickly as in 4 weeks, with a sharp increase in the first 6 months. And a final message would be hypertrophy hyperplasia is commonly caused by accumulation of plaque, hormonal changes, asthma medication, mouth breathing, and or amelogenesis imperfecta, if I pronounced it correctly.
You did.
I did. Well, there you go. So those are the take-home messages. Again, watch it back, put your screen on pause, and read through them in your own time. And take these messages to your own advantage. And as I said, I'm afraid this is it for today. Thanks so much for everybody who's joined us today and put in some questions. And I also wanted to thank the 2 amazing speakers of today. Starting with you, Alina, thanks so much for your impressive contribution. It was super, super interesting. So it was a pleasure having you on.
Oh, it was my pleasure being on. This was absolutely wonderful.
Thanks. And to you as well, Maria. It was such a pleasure listening to your expertise as well. And good luck with all your work and your research at the university, of course.
Thank you for having us, actually. I can't believe the hours already passed. I felt like we were just getting started. So
we were warned in the beginning, and it became true. But there we are.
I was just getting comfortable. I'm like, oh, this is great.
We can continue the discussion backstage afterwards. No worries. For those who are still watching in the audience, don't forget to subscribe to our YouTube channel so that you stay up to date for the most recent videos that we publish there. You can also find us on Twitter and LinkedIn at Sunstar Global. You can visit our websites, sunstar.com, the sunstarfoundation.org, and sunstargum.com. If you missed us last month, you can watch back that conversation. It was on periodontology for free as well. just have a look at our Let's Talk Oral Health playlist in our YouTube channel. By the way, this playlist is packed with other very interesting conversations and webinars as well. So just go on and have a look. We will be back next month, the 1st of June, with another episode of Let's Talk Oral Health, where we will discuss home-based oral care and how it can support cancer therapy. So it's quite intriguing, I think. As always, keep an eye out on this channel. Thank you again, and catch you all next time. Goodbye all.
Bye.
Bye.